So some of our objectives for today are to just understand the current epidemiology of HIV, hepatitis, and STIs, including chlamydia, gonorrhea, and syphilis in North Dakota. And then from there, identify the connection with those and substance use. And then lastly, identify opportunities in which we can expand comprehensive services for patients that potentially have infectious disease and substance use issues as well. Next slide. So this slide just shows our morbidity for these conditions in 2021. Our highest morbidity is among chlamydia, and we had 3,965 cases, followed by gonorrhea. Chlamydia and gonorrhea can often go hand in hand. Usually for among people that are getting diagnosed with chlamydia and gonorrhea, it tends to be on the younger population between 15 and 24. More females more so than males. The struggle with chlamydia and gonorrhea is that they can often be asymptomatic, and so without routine screening, these infections might not necessarily be identified. But if people are symptomatic, it'd be symptoms such as painful urination and discharge. Next would be hepatitis C, which is a bloodborne virus that causes inflammation of the liver. And we had 653 cases reported in 2021. Followed by syphilis, which is again a bacterial infection transmitted sexually. There are different stages of a syphilis infection. So the first stage would be primary syphilis, in which someone was initially infected and they have a symptom of a chancre, which is like a painless ulcer where the bacteria entered the body. It's often painless again, so people will just dismiss it, and then it will go away on its own without treatment. And then from there, it'll progress into the secondary stage, and the primary symptoms of the secondary stage are a rash on the hands and the feet mostly. And again, if people aren't treated during that stage, it will resolve on its own, and then it'll go into what's called an early latent stage, where there are no symptoms, but we know that that person was infected in the previous year. And then from there, again, if people aren't treated, it'll become a latent infection. And when it's a latent infection, it can have some long-term issues with the heart and neurologic systems as well. Syphilis can also cause neurosyphilis, in which it impacts the brain, and then also ocular syphilis, which people can lose their eyesight. And unfortunately, we have had cases of that here in North Dakota. So the important part with syphilis is identifying it as early as possible and getting people treatment as early as possible so they don't have those long-term effects of it. Next is hepatitis B, which again is also a bloodborne virus that impacts the liver, similar to hepatitis C. And then lastly, we have HIV, which can be bloodborne or sexually transmitted. There is no cure for HIV, but there is a treatment for HIV, so people can live long, healthy lives with HIV. Next slide, please. I just included these slides just to kind of show where the majority of our cases reside. So the top left map is our gonorrhea rates for 2021, pretty widespread across the state. And then on the bottom right is syphilis. So not as common, obviously has much lower morbidity, but it's still pretty widespread across the state. Next slide, please. And then the top right on this one is our HIV prevalence. So it's not just people that are newly diagnosed with HIV, but anyone that's currently living in North Dakota with HIV. As of December 31st, 2021, we had 520 people known to be living in North Dakota with HIV. And again, it's pretty widespread throughout the state. Cass County does hold nearly 50% of the people living with HIV in 2021. And then the bottom right is our hepatitis C. So again, pretty widespread there. I do want just to make a note that an individual's area of residence is where that's counted in this map is where they were diagnosed at the time. It might not be where they're currently living. If someone is incarcerated, it would be included in that the county of that correctional facility as to the morbidity. Next slide, please. So just to get into a little bit of our case investigations, currently our field services will investigate all reports of gonorrhea, syphilis, HIV, hepatitis B, and then now just most recently hepatitis C, starting in just this past spring. Previously, we only would investigate acute hepatitis C. And so what that kind of looks like is the field epidemiologists will get assigned a case based off of their region, and they will obtain clinical information. So they'll want to see if someone has symptoms, did they receive treatment for that infection, any other pertinent information, are they pregnant? And then from there, they'll actually interview the patient themselves to understand kind of what their risk history might look like, and then identify any contacts that might also need to go in and get tested and treated. So currently we have 8 regions across the state that have field epidemiologists. There's one in Williston, one in Dickinson, Bismarck, Minot, Devils Lake, Jamestown, Grand Forks, and Fargo. And then we also have Jennifer, who is the assistant to the field director and also does training, and then our field services director as well. And they will also assist in field investigation if need be in those areas. Next slide, please. So to kind of get into a little bit of the risk factors of people that are diagnosed with gonorrhea and syphilis, in 2021, 22% of the gonorrhea cases reported injection drug use, and 52% reported having sex while intoxicated or high in 2021. And then for syphilis, it was 16% reported injection drug use and 60% reported having sex while high or intoxicated in 2021. Among persons who use drugs, stigma and mistrust of the healthcare system, along with other social determinants of health, such as unstable housing, poverty, incarceration, can contribute to decreased healthcare utilization, and then reluctance or inability to identify or locate sex partners, resulting in delays in diagnosis and treatment. And then also when people are having sex while high or intoxicated, their inhibitions are lowered, so they might be performing in riskier behavior, such as having sex with multiple partners or not using protection while they're having sex. And again, these are just patients that we were actually able to interview either ourselves or through a healthcare provider. So it wouldn't be all of the reported cases of gonorrhea and syphilis, but still a very high percentage that report some sort of substance use. Next slide, please. Next, to get into HIV, 12% of everyone, so our HIV prevalence of that 520, reported injection drug use as a risk factor, whether it's by itself or they were also having sex with male men that would have sex with other men. And then 16% of our newly diagnosed in 2021 reported injection drug use as a risk factor. And nationally, it's about 1 in 10 new HIV diagnoses that are attributed to injection drug use, again, whether it be injection drug use alone or injection drug use and male-to-male sexual contact. The risk of getting or transmitting HIV is very high if an HIV negative person uses injection equipment that someone that with HIV has used. Needles, syringes, and other injection equipment can contain blood in them, and that blood may carry HIV. HIV can survive in a used syringe for up to 42 days, depending on temperature and other factors. And then also substance use disorder can again increase the risk of getting HIV through sex. When people are under the influence of substances, they're more likely again to engage in riskier sexual behaviors, having anal or vaginal sex without condoms, like I mentioned, multiple partners, or even trading sex for money or drugs. Next slide, please. So these are the male HIV risk factors, or people that identify as male in North Dakota. So you can see the gray and the blue are injection drug use. So we've definitely had cases reported every year for the past 5 years of some form of injection drug use. Prior to the previous 5 years, it was a little less uncommon. So we definitely are seeing increases there. Next slide, please. And then this is the female risk breakdown. So again, that blue color is the number of injection drug use that has been reported. So we just saw it in 2020 and 2021 among female cases. Next slide, please. In terms of hepatitis C, We did not do routine investigations of hepatitis C, like I had mentioned. We'd only follow up on acute hepatitis C, but acute hepatitis C is very limited and often not reported. We had no cases of acute hepatitis C reported in 2021. And that's because, again, people are often asymptomatic when they are first infected with hepatitis C, or they'll have very generic symptoms. So they'll just think they're a little under the weather and then it'll resolve. Or they haven't had a routine testing history to know whether or not it's an acute infection. In 2018, we did do an enhanced surveillance project just for a short term, just to identify what risk factors were present for people 35 and younger. And of those that we were interviewed, 88% reported injection drug use, whether it be past or present. But now, thankfully, we have more funding for hepatitis C, which is great. And so in the spring of this year, we did start routine surveillance of all newly diagnosed hepatitis C infections. And so what that looks like is anyone that's newly diagnosed is referred to a field epidemiologist and they will contact them. Again, follow up on that clinical information to see, could this possibly be an acute infection? And then also interview that patient to understand their risk factors, let them know that there is a treatment or cure for hepatitis C and refer them to a healthcare provider for that. So our preliminary data for 2022, again, it's just a short term. We started in about May, 76% overall report injection drug use, but it increases up to 90% when looking at those age 35 and younger. Next slide, please. In North Dakota, we have what are called CTR sites. They're counseling, testing, and referral sites. And the CTR program is aimed to provide HIV and hepatitis C testing at no cost to people that are at risk for those infections. There are many different sites across North Dakota. They can be local public health units, they could be substance use and treatment centers, family planning sites, correctional sites, homeless shelters, colleges, sexual health clinics, tribal health, kind of all across the board. Anyone that sees patients or clients that have high risk factors could potentially participate in the CTR program. So if your site is interested in offering testing like that, you can contact the Sexually Transmitted and Bloodborne Disease Unit, and we can get you more information on that as well. Next slide, please. This is just some data from our CTR sites regarding HIV testing. So in 2021, we had 4,049 people that were tested for HIV. We did see a big drop in 2020, and we're still hoping to see that increase back into 2022 just because of the pandemic. A lot of these sites, again, are local public health units, and they have other priorities such as vaccinations and stuff. So we did see pretty significant decreases in testing, but we'll hope to see that get back up. Next slide, please. Excuse me. This is the risk data that we obtain for anyone that's tested with HIV. They kind of go through the same risk profile and we'll refer them for different needs. But as you can see on here, drug use is pretty frequently reported. So overall drug use, whether it's injected, ingested, smoked, or snort, is 1,328 of the 4,000 cases. And then injection drug use is 783. And then of those, sharing injection equipment is 499. So it's a pretty high number there. Next slide, please. This is our hepatitis C rates that are being tested at CTR sites. So it's 1,575 in 2021. Again, a little lower than we had seen pre-pandemic, but we hope to see those numbers go back up. And of those tested, 34% identified as injecting drugs either currently or in the past. And of those, 65% reported sharing injection equipment. So again, it kind of goes back to HIV and Hep C can live in that injection equipment and it can spread to others. Next slide, please. So now we're going to kind of switch gears and I'm going to talk a little bit about vulnerability assessment. So there was a large outbreak in 2014 and 2015 of HIV among people who inject drugs in Indiana. And so that kind of prompted the CDC to do a national assessment to look at what other areas of the country might be at risk of having either hepatitis C or HIV spread among a population who injects drugs. Next slide, please. So this is a map from that assessment. The pink counties are the areas that the CDC identified as being highly vulnerable to having an HIV or Hep C outbreak in relation to injection drug use. There were 220 counties identified. As you can see, none of them are in North Dakota. And then the greeny blue shade of the states are states that have shown that they could be at risk for experiencing outbreaks, or they currently are at risk. So North Dakota did work in collaboration with the CDC to come to the term that we do definitely are at risk for that happening here in North Dakota. Next slide, please. And so that led us to do our own vulnerability assessment to see, comparing North Dakota's counties to North Dakota counties rather than at the national level, to see where in North Dakota might be at greatest risk of having these outbreaks in relation to injection drug use. So our criteria is a little bit different than what the CDC used. We looked at anyone that was newly diagnosed with hepatitis C in 2016 and 2017. We had to use a little older data just so it could coincide with local and national data sets that we had available data for. And then we only looked at those that were between the ages of 15 and 34. And that's because we had done that enhanced surveillance to know that 88% of people with hepatitis C under the age of 35 reported injection drug use. And so we found that would be the best proxy to use for injection drug use. We don't know how many people in North Dakota overall have injected drugs. And so this is the best metric that we could come up with. And then we looked at individuals who had a quantitative RNA result. So we know that they were currently infected with hepatitis C. They hadn't recovered from their infection. And then lastly, we limited people that were diagnosed within a correctional facility, because as I had mentioned earlier, those counties then would be at an increased rate, and it wouldn't actually be true. So by taking them out, we limited bias for those counties that have correctional facilities. And then we looked at different variables that could potentially impact this. So it was a group of stakeholders that got in a room and we discussed what could potentially be a factor in all of this. So we looked at things like drug overdose mortality, access to prescription opioids, different drug-related criminal activity, different socio-demographic characteristics, and things like that. And next slide. These are the 9 factors that became significant within our model. So being uninsured, not having health insurance, whether they're in an urban or rural classification, with rural being at higher risk, the percent poverty, teen birth rate, gonorrhea rate, percent unemployed, poor health rating. So this is how people actually perceive their own health, whether they think they're healthy or not, having vehicle access, and then a high school diploma. If you go to the next slide, please. And this is the map from that model. So the darker the shade of red, the higher the risk those counties are. So the highest risk would be Benson, then Rolette, Sioux, Montreal, and McKenzie. But when we did this model, we were limited on some of the data because we didn't have complete data for every county. And there was some data that we had that had high epidemiologic association with injection drug use. If you want to go to the next slide, please. And those were not included in the primary model just because we didn't have data for every county. And so we did limit that secondary model and we ran it just with those counties that had that variable. And when we did that, the only variable that was significant was amphetamine and methamphetamine incidence. If you go to the next slide, please. And so that changed our map. So then Burleigh County being the #1 county that could potentially be at risk for an HIV Hep C outbreak due to injection drug use. Can't say that either model is right. I mean, it's going to be a combination of the two. That's why we had to break it out to 2. And again, this data is a little bit on the older side, so we are in the process of updating this with more current data to see how it's changed. But we do know that there definitely are counties in North Dakota that are higher risk compared to other counties. And so what does that mean? You know, how can we offer services in those counties? If you want to go to the next slide, please. I wanted to include this in here as well. This data, again, is a little bit older. It's from January 2019 just through August 2019. But this dashboard is on the website for anyone to go and access. And so in 2019, just between those January to August, there were 38 preliminary drug overdose deaths. And if you want to go to the next slide, please. And then since then, we have started a violent death reporting system. And so this data is more current. It's as of 2021. Again, it's still preliminary, but there were 131 drug overdoses in North Dakota. So at the end of this presentation, I did include the links to these different dashboards so that anyone can go on and look at this data themselves. Next slide, please. So lastly, what I wanted to talk about was then the harm reduction piece of all of this. We know that a large percentage of people diagnosed with STIs and HIV and hepatitis report some sort of substance use. And so what can that harm reduction look like? Currently, North Dakota has 5 syringe service programs throughout the state. And then also on our website, we have different educational and prevention supplies that any site can order. So the slides are shared, you can click on the order here and that will bring you to our website. And on there we have different brochures and pamphlets about the conditions, posters people can use, anyone can order condoms to distribute, dental dams, lubricant, and then safer sex kits as well. Next slide, please. So these are the syringe service programs that are currently in North Dakota. There is the Any Positive Change Project out of Grand Forks, the Harm Reduction Center out of Fargo, the Mandan Good Neighbor Project, the Minot Good Neighbor Project, and then the Ropes Project, which is out of Valley City. We would like to see more syringe service programs provided throughout North Dakota, but 5 is a good start. They are heavily utilized. We do see a high rate of not just syringes distributed, but syringes also received back to be disposed of properly to reduce the risk of transmission of HIV and hepatitis C. I don't have current data because of the pandemic. It hasn't been published yet, but you can find old reports on our website that show just the amount of syringes that are given out, and not just syringes, other services that can be provided at syringe service programs, such as vaccination for hepatitis B and hepatitis A, among other things. It's not just the syringes that are given out. There's other harm reduction, such as prevention supplies as well. Next slide, please. So what we would like to see is kind of increased testing and other services that are available. There are a lot of people that are living with HIV or hepatitis C that don't know that they are infected. Substance use facilities are definitely an avenue to increase testing among a high-risk population. HIV is, again, treatable. 83% of the people that are living with HIV in North Dakota as of the end of 2021 are virally suppressed, meaning that they cannot then transmit their infection to other people sexually. And then hepatitis C is curable. We would really like to see the rate of people getting treated for or cured for their hepatitis C infection to increase. And then again, chlamydia, gonorrhea, and syphilis are all curable as well. And then at the same time, we can provide vaccinations for hepatitis A and hepatitis B, and really making sure that we're offering comprehensive services to these populations. Next slide, please. This is just the resources. So these are the different dashboards, and then the syringe service program website that is available for all to reach. Does anyone have any questions before Jennifer gets into the case presentation?
Again, feel free to unmute and ask a question or throw it in the chat box. And I will be sending out an email following this echo session with all of the links to the resources that have been shared in this session.
So this is Carolee from Heartview. I do have a question in regards to educational supplies that you had talked about, like with the safer sex kits and things like that. So
Yes.
we do a lot of different educational things with our patients. So is there a limit to the number of kits? Is there what would you consider best practice for that?
I mean, we definitely do have limited supplies, but we don't want to limit people to what they can order. So I would just recommend going on to our website and even just ordering a few just to get an idea of what they are. And you can work with our prevention coordinator if you need to order mass amounts.
Okay.
She'd definitely be able to help on that side.
Okay, awesome. Thank you.
Yes.
Okay, and I think we will move on to the case presentations, and any questions beyond that can just, I think, be asked later, or if something pops into your head and you need to share, just please jump in at any point.
Well, thank you again, Julie and Sherry, for your great information there. Sherry, that was great to set us up for this case presentation. So I'm just going to go ahead and get us started on this, because then I have several questions for the group to go through after I've given you the information on this case. So we have a 35-year-old Hispanic male. He did seek services for STD screening in September of 2021, where the individual ended up being positive for gonorrhea. So that then lent itself to being investigated by a field epidemiologist. During that investigation, the field epidemiologist, the individual did not declare any risk factors that would have had us wanting to refer the individual for HIV PrEP services. For those of you that aren't familiar, PrEP services is a one daily pill or other form of medication that can prevent an individual from contracting HIV. And there was no risk factors identified for that to take place at this time. It's September 21. And also the individual tested negative for HIV. They did declare during that partner service interview by our DIS, disease investigation specialist, that they are a substance use. They do use substance, but we don't know at the time of that interview in September if it was current use or if it's past use, as when that question is solicited, there is no time frame associated with that. And then we did learn subsequently in June of 2022 that the individual had a case manager with a regional human service center. However, we were not aware, the field epidemiologist was not aware of that in September 2021 when we had the first interaction with the individual. Next slide, please. So on Friday, May 27th, this individual was tested at a dual diagnosis residential facility. North Dakota Health and Human Services Public Health Division believes the testing was prompted by a screening that the individual admitted to exchanging sex for alcohol. On that following Wednesday, June 1st, the individual reached out directly to the public health unit per the direction of the dual diagnosis residential facility. The individual called on their own just to a general phone number at public health and was directed to somebody who visited with them. And this is some of the quotes that were provided in the chart at the time. He was very nice, but expressed that he had a very difficult time with the diagnosis, which then had him back at the dual diagnosis residential facility. I told him I was proud of him for being tested, and that while this next chapter seems to be like a big unknown, we were here to help him on his journey and that things would be well for him. I let him know that a DIS would be getting a hold of him, and I also let him know that DIS would introduce him to Ryan Wright, coordinator. Next slide, please. A Ryan Wright coordinator in North Dakota helps with financial assistance related to HIV care. So then on Friday, we were not sure why the individual went and sought retesting. The individual went to an urgent medical care clinic and was retested for HIV. We can assume this may be due to a denial, but we do not know why the individual went and did that. Then on Monday, June 6th, our DIS set up an appointment to meet with the individual in person at a public health unit to conduct that partner service interview, and then of course to introduce them to a Ryan White program. On Thursday, June 9th, the individual did not show up for their public health appointment. The DIS and the Ryan White coordinator reached out to the patient via phone, and the individual was incoherent and intoxicated. The DIS and Ryan White coordinator offered to dispatch help, but the individual declined. The next day, Friday, the individual reached back out to our DIS and was willing to meet and go over the next steps. That meeting did happen later in the day. During the meeting, though, the individual he did want help and was seeking services. However, they were very visibly intoxicated. They also had no form of transportation. I put a little, just to kind of give you a frame of reference here of when all of this took place for this individual, this HIV. So we had the May 27th with the individual being tested. We don't know from the dual diagnosis facility when those results were expressed to the individual. It may have been on June 1st. Because the dual diagnosis facility is not talking directly with us at public health. So we're just not sure what happened here. June 1st was when that contact happened to the general number the individual called on their own. June 3rd was the additional test being done. We're not sure why that was done like I said, we're kind of assuming the individual is maybe in a state of disbelief and wanted it confirmed. Then June 6th is when that initial contact happened from our DIS to the individual. The person didn't show up on June 9th, and then we did finally get an in-person meeting with the individual on June 10th. So it happened quickly. It was a little bumpy, but we definitely did happen. But remember, prior to all of this and this HIV diagnosis happening, this individual was seen at a medical facility back in September. So just was that 9 months previously, and didn't declare any risk factors. Next slide, please. So I wanted to talk with all of you here at this table, virtual table. As I kind of shared with you, you can see how public health didn't really have communication with the had zero communication in a way with the dual diagnosis facility, and really felt a little left-footed, if you will. And then when the individual was with them, the DIS, and they were intoxicated, was there something that the DIS could have done? Who could they have reached out to? And so those are some of the things as we're going through these questions. I'm really hoping those from the group will unmute themselves so that we can grow better together through this process. So my first question is, what barriers prevented the dual diagnosis residential facility from facilitating that introduction to public health? They did a good job of letting the individual know to call public health, but is there a reason why they weren't in the room, if you will, or didn't give us a call? Because they know that they're required to report that lab test, but where's the disconnect where they think they can't talk to us about the individual? So I think I saw something pop up quick in the chat, ROI. What else is there? And I don't have the answers, so I truly am looking to you for the answers. So I'm going to address the ROI thing real quickly. When it comes to an infectious disease, HIV is covered under Century Code, in which you're actually required by law to discuss that with the health department. So for those of you that don't know that, it doesn't mean that you have to be the person who reports it, and we'll discuss that more in other presentations later on, but that you can and should discuss that with the right people at public health. And then we have another comment, but it's not covered under 42 CFR, and I don't know what that means. So Crystal or somebody else want to expand on that?
42 CFR is another level of confidentiality specifically relating to substance use disorder. And unfortunately, even though under Century Code we are allowed to share that information, 42 CFR permits us from sharing that information from our standpoint through addiction services.
And there's no, because of the addiction services and there's no avenue whatsoever that anyone at this table is aware of that could have had the dual diagnosis facilitate that phone call. Kim put in the chat that we could ask the patient to sign an ROI.
Yeah, this is Kurt Snyder from Heartview. Usually, most often, it's not a barrier, it's just a step needed. You know, that's not really a threatening release of information. A lot of times they want more information as well. So I think that that's something that isn't, it's a barrier, but it's very doable. I think a good solution for this is the public health office and the residential facilities throughout the state having a better relationship to where, for example, maybe public health comes in and does educational opportunities for the patients. And so when that time does happen, it's an easy, I know who to call and I know the number and I know the person. So some good solutions for it anyway.
Thanks, Kurt. And we're really hoping through this Project ECHO, we can definitely start the building of those relationships for that to become easier. Rachel put in the chat, what about communicating need for treatment to facilities? At times, someone will communicate a partner that is in treatment, and we are unable to confirm that we have referred in for treatment or testing, as facilities cannot always confirm if the person is staying there. That is a big gap. So what Rachel is saying is, so she has somebody who is HIV positive and they've named someone as a partner, and they say, but I know they're receiving treatment at such and such a facility. Public health can reach out to that facility and say, Jane Doe should be screened for HIV. And then what she's saying is, we're not able to get information back from that facility to say, yes, Jane Doe is here, and yes, we'll screen her. And I'm guessing it has to do with this 42 CFR. Okay. I just experienced a public health call on a client, and the issue was that the patient was not active in services, so we were unable to obtain an ROI. Okay, that's a good point. I'm going to go ahead and move on to number 2 here. What does the dual diagnosis residential facility have for providing a life-changing diagnosis such as HIV? So, you know, just thinking about your own facilities, if you are testing and screening and testing for HIV, which we fully support here at the Public Health, we just want to make sure that you have the resources at your disposal to be able to give those results. And if you don't, what do you need from Public Health so that we can help facilitate that? Okay, well, we'll leave that one up in cyberspace for a little bit. What would how would Public Health know the individual had a relationship with a dual diagnosis residential facility? So in September, when the individual was seeking STD services and tested positive for gonorrhea, a field epidemiologist like myself was in conversation with them. However, they denied much of anything other than that they had been or are a substance use user, if you will. So is there something that we could be asking differently during that first interview? But then in June, when the individual did meet with the Public Health DIS in person and they were intoxicated, is that a point in which we should be reaching out to that dual residential facility? Because we knew where the test came from, so we know that there was a relationship. Should there have been some follow-up there on our side?
This is Kurt Snyder again from Heartview. I believe that, yes, that's a great step that could be taken. And a little trick around 42 CFR from a treatment provider's perspective. If public health knew that the test came from there, knew that there was that relationship, but maybe there's not a release. So you call and you get, I can't confirm or deny knowledge. Well, one thing that we can do as treatment providers is we can listen without acknowledging, right? There's no reason why as you could call and say, hey, you don't need to say whether they're there or not, but I want you to know that X, Y, and Z. So it's still a good way of passing information. But once again, that relationship really would break that barrier down.
Okay, great. Thank you, Kurt. Jennifer put in the chat here, we are a CTR site and we are seeing more and more people refusing to answer the screening and demographic information. That's hard. That's hard. Thank you for sharing that, Jennifer. Maybe we'll have to have we'll have some more on motivational interviewing for some of us in public health, and we can use our friends over in behavioral health to school us in that. So that's right up their alley. When the DIS ask about substance use, should we be asking if it's a current user or if the individual would be like to hear about harm reduction? Like I said, at this time, we're not asking if it's a current and past. Is that something that our behavioral health partners would recommend that we switch up the verbiage? And then with that said, if they were to say that they're a current user, should we also then ask if they're ready to want to hear about harm reduction, or that we can refer them to some information? I know I have some DIS on the call. Do they have an opinion on that question?
I'm here. I'm one of the newer ones, but I'm probably one of the more awkward ones. So I guess I will just say that usually when I ask people that question, sometimes they'll tell me, I'll just say, oh, is there, and how about drug use? What's that look like for you? And, if folks are current, sometimes they will disclose that. Other times they'll just say yes. And I usually just frame it as it's a risk question, because maybe there's more testing or more resources I can get you in for. People that are sober or have completed treatment tend to be pretty proud of it. So a lot of times they'll tell me like, oh yeah, I used to use meth, but I don't use that anymore. It's been 3 years and 3 months or something. So, but going through that history still, kind of can prompt me to know if maybe they need to get in for, some HIV or Hep C testing. So I guess I tend to let people take that conversation where they take it and see what happens first.
Thank you, Rachel.
This is Jen from Custer Hill. And just from working with the syringe, excuse me, just from working with our syringe service program here in Mandan, I think it is a very important question to be asking if they're a current or former user, just because if they are currently using, obviously you want to get them in for the hepatitis C HIV screening. But like I've talked with Sarah Winninger, it's not if we have an outbreak, it's when, because doing the program, we do have people with HIV who do admit to sharing supplies, which is extremely scary and gives me a lot of anxiety, but it is happening, and it is happening here in our communities. So if we can, capture that information, refer them to harm reduction services, provide them with education and referrals and resources to be safe for themselves, their family, the community, it's definitely a stepping stone that we need to be taking advantage of.
Thank you, Jennifer. And then a follow-up question for my DIS. Are you familiar with harm reduction availability in your regions? Oh, I got a yes in the chat here from my central region, Bismarck, Mandan, and that area. And I got another yes from my eastern portion. So we've got some participation here from our DS. So let's go ahead and move on to question number 5. So in September, the individual declared no risk and only female partners, no admittance when asked if they ever exchanged sex for drugs or money to indicate a referral for PrEP. But in June, They did disclose that their sexual partners were both male and female, and they admitted to exchanging drugs for sex for drugs or money. What could have the provider done in September to identify this risk? And just kind of as a note, he reached out wanting help. How does public health link them to behavioral services in a crisis? So as we went through the story, you saw where when public health was reaching out to this individual, they were intoxicated and incoherent. So clearly in a crisis. How could we have reached out directly to get that person into help? And then not only our DIS, but also the healthcare provider that the individual went and saw in September. What could the provider have done to get to have this individual be comfortable to share what was going on? In the chat, I've got a few more of my DIS responding that they're familiar with harm reduction in the area, so that's fabulous. And then we have, I think doing a sexual health history is important with patients, using an inclusive and open language, allowing the patient to answer questions open-endedly. So in September, the medical provider that did that test, we're not privileged to what that interview looked like. We don't know, but that patient just wasn't honest. And so then there could have been some prevention measures so that the individual would have maintained being negative for HIV. Excuse me. Subject criteria that flag an individual eligible for PrEP includes bacterial STIs or a history of inconsistent or no condom use. If this patient was diagnosed with gonorrhea infection, he would have been eligible for PrEP at the time of the first medical visit. Yes, Crystal, you are correct, but most individuals or most healthcare providers currently, they're really looking for men who have sex with men. So with this individual not declaring that, wouldn't have been put into that group. But you are right, Crystal, the things have been updated for who's eligible for PrEP, and it pretty much puts everybody eligible for PrEP if you're having multiple partners or having had been diagnosed with the bacterial infection. So I want to go back then to my second question here. This individual was in a crisis, and Kurt has alluded here a couple of different times about getting that partnership between different services going between public health. Maybe then we could have in this particular crisis had a phone number, had a person to call to get this person back where, not necessarily back where they needed to be, but clearly public health is not equipped. This isn't our lane. We're not equipped to deal with this other issue that the individual is dealing with their addiction. So any thoughts in addition to continue this table discussion and getting to know each other so that we can feel better about who to call and when? Any other little nuggets of thoughts there for how public health could have linked this individual in this crisis? Okay, so definitely maybe something we want to flush out.
I'll step in again, Kurt from Heartview. I think this falls upon treatment providers as well. Having that diagnosis for somebody that's in our care offers an opportunity to add that to our treatment plan to really, hone up on our information as well and making sure that we're providing that patient with the best information and education and connecting them with him or her with the right services, which would include public health or whatever. So I think that's definitely falls on both sides.
And then my last question here is, it was shared by the DIS that this individual really had no means of supporting himself, including transportation. What social service referrals could have happened for this individual in this crisis?
This is Carolee. I think part of what could happen is really referring them on to see if they are eligible for Medicaid expansion, and some of those types of services that would allow them to possibly get transportation to different appointments and things like that.
And when an individual is diagnosed with HIV and they're introduced to the Ryan White coordinator, that is one of the very first things they do is they discuss their Medicaid eligibility.
Jennifer?
Yes, Rachel.
Yes, I know that a barrier that I've seen sometimes is transportation. And I know that like Medicaid expansion, there are certain, programs that will pay for medical transportation, but sometimes time is of the essence, and expecting someone to complete that paperwork, get approved, and then be able to access a ride service can be a problem. So I guess that's something I would want to know if there's, a program I'm not aware of. Something else I would like to bring up is, how we could better connect, or is there a way for us to know if someone's involved with, a regional treatment or something, like if they've got an additional human services worker who might be able to help navigate that part. It seems like that's just kind of always missing in connection, and I wish it wasn't.
Yeah, that's a really great point, Rachel. Thank you for bringing that forward. So being mindful of everybody's time, we only have a couple minutes left here. Are there, and I posed a lot of questions to the group. Are there questions for myself or Sherry?
We did have a question come in, excuse me, before the bulk of the discussion started. This might be for Sherry, but I'm not sure. It says, I've had a few clients who stated that they were diagnosed with hepatitis C, but were not able to receive treatment for it due to not having 1 year of sobriety. Is this a requirement for all or most hospitals across North Dakota? And what is the reason for requiring that?
So that is a Medicaid requirement, and it's 3 months. So they have to be tested for drugs twice with 3 months in between. Medicaid in North Dakota, we get rated on hepatitis C access, and it's currently a letter grade of a D, which is not good. If you're in school, you don't want a D. So it's something that we are aware of and constantly having conversations about. But yes, there is a sobriety requirement currently with Medicaid for 3 months.